All right, let's dive right in. We're breaking down the brand new 2024 ACG guideline for treating H. pylori. And let me tell you, this is a major shift in how we practice. So let's get into what you absolutely need to know. Here's the game plan. We're going to cover why our old go-to treatments just aren't cutting it anymore, what the new first-line recommendations are, what to do when that first attempt fails, and then we'll look at the rise of tailored testing. And we'll wrap it all up with a quick and easy checklist for your practice. So why the huge update? Honestly, it all boils down to this one number, 31.5%. That's the estimated rate of clarithromycin resistance right here in the United States. Think about that. It means that for nearly 1 in every 3 patients you see, our old standby therapy was doomed to fail from the very start. And that number leads us directly to this quote, which is really the heart of the entire guideline. The message is crystal clear. The days of just empirically prescribing clarithromycin or levofloxacin are over. Done. We just can't do it anymore without proof that it'll actually work. Okay, so let's start with the main villain of this story. The rising tide of antibiotic resistance that's made our once reliable treatments basically obsolete. You know, we all learned it in training. We've all prescribed it. Standard PPI clarithromycin triple therapy was the absolute bedrock of H. pylori treatment for years. But the evidence is now just overwhelming. Its effectiveness has completely plummeted to unacceptably low levels for a massive number of patients. And this chart, wow, it tells the whole story, doesn't it? Look at that stark contrast. Resistance to clarithromycin is over 30%. For levofloxacin, it's pushing 40%. But then you look over at amoxicillin and tetracycline, both are sitting pretty at under 5%. The data is literally screaming at us, telling us which tools in our toolbox are still sharp. Okay, so with that resistance data burned into our brains, what's the new game plan? What are you actually supposed to write on that prescription pad for your next patient who's never been treated before? So here are the new heavy hitters. The top recommendation, your new default, is 14-day optimized bismuth quadruple therapy. And that word optimized is key. We'll get to that. But you've got strong alternatives too, like rifabutin triple therapy and PCAB dual therapy. Now, you probably noticed a new acronym on that last slide, PCABs. That stands for potassium competitive acid blockers. This is a whole new class of drug, and it's a true game changer for acid suppression, which, is absolutely essential for letting the antibiotics do their job in the stomach's hostile environment. So, you might be wondering, what's the big deal? PPI, PCIB, what's the difference? Well, it's actually pretty significant. PCIBs, like vonoprazan, work way faster, they give you stronger and longer-lasting acid control, and you don't have to worry about timing them with meals. But here's the real kicker. Their effect isn't altered by a patient's genetics, that CYP2C19 status, which is a huge variable with PPIs. It just means more reliable acid control for everyone. But let's be real. No treatment works 100% of the time. So what do you do for that patient who comes back and their test of cure is still positive? The good news is the new guidelines give us a really clear, super simple algorithm to follow. The whole decision tree really comes down to one simple question you have to ask. Has this patient already had a proper course of bismuth quadruple therapy? Your answer to that one question tells you exactly what to do next. If the answer is no, they have not had BQT yet, then that's your next move. That's your go-to second-line therapy. But the key here is making sure it's truly optimized. That means a full 14 days, the right dose of metronidazole. And, this is important, using tetracycline, not swapping it out for doxycycline, which just isn't as effective. And, of course, a twice-daily PPI. And if the answer is yes, they've already had a solid, optimized course of BQT and it failed, then the next logical step is rifabutin triple therapy for 14 days. This makes perfect sense, right? It uses a completely different set of antibiotics, including rifabutin, which has incredibly low resistance rates right now. All right, for those really tough, stubborn cases, especially after a couple of treatments have failed, the guidelines are pointing us toward a much more personalized, precision medicine approach. This is the cool stuff. This is where we stop guessing and get precise. We can now actually test the bacteria's DNA, either from a biopsy or even from a stool sample, to see exactly which antibiotics are going to work and which ones won't. This isn't science fiction. This is the future of managing H. pylori. So, when do you actually pull the trigger and order one of these tests? Well, the experts say you should really start thinking about it after 2 or more failed treatments, or if your next best options like BQI or rifabutin just aren't possible for some reason. And for sure, you should do it before you're ever forced to even consider using a high-resistance drug like clarithromycin or levofloxacin. Okay, that was a lot of information. So let's boil it all down into a few essential practice-changing takeaways for the very next patient you see with H. pylori. Here it is, your new playbook in 3 simple steps. Number 1, your new defaults, your go-to first-line treatment should be 14-day optimized BQT. Number 2, avoid the old standbys. No more just casually prescribing clarithromycin or levofloxacin. And number 3, confirm you've actually cured the infection with a test of cure in every single patient. No exceptions. And that last point brings us to one of the most critical and honestly, one of the most frequently missed steps in the whole process. The guidelines are explicit here. You have to test every patient every single time. Just because their symptoms got better doesn't mean the bug is gone. The new mantra is simple. Don't assume, confirm. And look, this isn't just about checking a box. For your patient, it's about preventing the serious long-term risks of a lingering infection like ulcers and even gastric cancer. And for you, it's a quality control check. It's the only way you'll ever know if the treatments you're choosing are actually working in your own community. So the takeaway here is pretty clear. The resistance patterns have shifted dramatically, we have better therapies available, and because of that, the standard of care for H. pylori has fundamentally changed. The only real question left is, now that you have this new evidence, what are you going to do differently tomorrow?